This recorded lecture will be going over Unit 5 in the ATI-PN Mental Health Nursing Textbook. This will be covering chapters 27 and 28. Chapter 27, Care of Clients Who Are Dying and/or Grieving. Clients will experience loss in many aspects of their lives. Grief is the inner emotional response to loss, and it's exhibited in many ways as there are individuals. Bereavement. This is grief and mourning. Mourning is going to be the outward display of the loss, what they are showing to everyone else. These will be seen as a person deals with the death of a significant individual. Bereavement can result in depression. A bereavement exclusion was previously used when a patient would experience manifestations of depression within, within the first 2 months after a significant loss. That's now been changed. Now, a patient can actually receive a diagnosis of depression during that time of the first 2 months after that loss of a significant other. The reason being for that is so we don't have to delay any needed treatment for these patients. End-of-life issues will include decision-making in a highly stressful time. During these times, the nurse needs to consider the desires of the patient and their family. End-of-life care can include palliative interventions, which promote comfort. Let's look at the different types of loss. There is a necessary loss. This is part of the cycle of life. It is anticipated, but it can still be intensely felt. There is an actual loss. This is a loss of a valued person or item. There is a perceived loss. This is any loss defined by a patient that is not very obvious to others. There's maturational loss. This is a loss typically expected due to the developmental processes of life. And there's a situational loss. This is unanticipated loss that is caused by an external event. Next, let's look at some theories of grief. It's important for a mental health nurse to be aware of these different theories. Although there are multiple theories present, they each will identify the same underlying feelings that the patient who is grieving will experience. These patients may not always experience these stages or tasks in the same order, and the length of time required to progress through these stages can vary from individual to individual. Let's first take a look at Kubler-Ross, 5 stages of grief, and this should be a good review for you all. Starting with denial. The patient will have difficulty believing a terminal diagnosis or loss. Progressing into anger. That anger can be directed towards themselves, others, or objects. Next will be bargaining. They will negotiate for more time or for a cure. They'll move on to depression, where they feel overwhelmingly sad by the inability to change their situation. And hopefully they eventually move on to acceptance. This is where the patient accepts what's happening to them and begins to plan for the future. Let's look at Bowlby's 4 stages of grief. This identifies behaviors observed in patients who are grieving, and these stages would be present in patients as young as 6 months old. Numbness or protest. In this stage, the patient is in denial over the reality of their loss and begins to experience feelings of shock. They move into disequilibrium, where they focus on their loss and have an intense desire to regain what they lost. They'll move into disorganization and despair, where they feel absolutely hopelessness, and this impacts the patient's ability to carry out their tasks of daily living. And hopefully they move into the reorganization phase, where they will reach an acceptance of their loss. Next, let's take a look at Engel's 5 stages of grief. We begin with shock and disbelief. The patient experiences a sense of numbness and denial over their loss. They move into developing awareness. They become aware of their reality and the loss, resulting in intense feelings of grief. This stage will begin within hours of the loss. They'll move into restitution. This is where the patient carries out cultural and religious rituals, such as a funeral, following the loss. They'll move into resolution of the loss. This is where the patient is just preoccupied with the loss. This can occur over about a 12-month time period and then should gradually decrease. Finally, we hope that they move into the recovery phase, where they can move past their preoccupation and move forward with their life. So much easier said than done, unfortunately. Next, let's look at Worden's 4-task of mourning. With these stages, completion of the 4 active tasks will empower the mourner to resolve their grief. Their first task is accepting the reality of the loss. Their second task is processing the pain of grief. They need to use their coping mechanisms to deal with the emotional pain they feel from this loss. The third task is adjusting to a world without the lost entity. The patient will need to change their environment to accommodate the absence of the deceased person. And finally, task number 4. They need to find an enduring connection with the lost entity in the midst of embarking on a new life. The patient needs to find a way to keep that lost entity as a part of their life, while at the same time moving forward with their life and establishing new relationships. And again, so much easier said than done. And we always want to keep in mind that our patients will progress through these stages at varying time lengths, and that there truly is no identified period for how long grief should last. So it's quite subjective and on an individual case-by-case basis. Factors influencing loss, grief, and coping ability. This will include the patient's current stage of development, their interpersonal relationships and a social support network, the type and significance of their loss, their culture and ethnicity, their spiritual and religious beliefs, their prior experiences with loss, as well as their socioeconomic status. Some risk factors for complicated grieving include being dependent upon the deceased, an unexpected death at a young age, such as through violence or a socially unacceptable manner, inadequate coping skills that the patient has, or a lack of social support, and any pre-existing mental health issues, such as depression or substance use disorder. What are some nursing actions that we can do? Well, we always need to assess our patients for any risk factors, as well as to identify a normal versus a complicated grief response. So let's begin to look into that. Normal grief. This grief is considered uncomplicated. These patients should achieve some form of acceptance by 6 months after their loss. Some somatic manifestations that grief can cause includes chest pain, palpitations, headaches, nausea, changes in sleep pattern, or fatigue. Anticipatory grief. This is a grief that implies of letting go of an object or person before that actual loss occurs. This could happen in the case of a terminal illness. In this type of situation, the individuals will have an opportunity to grieve before the actual loss occurs. Then there's complicated grief, and we have different types of complicated grief. There's delayed or inhibited grief. In this type of grief, the client will not demonstrate the expected behaviors of a normal grief response. They can remain in the denial stage for an extended period of time. Due to their inability to progress through these stages, a subsequent minor loss, even years later, can trigger a grief response. Then there's distorted or exaggerated grief response. This will exaggerate the feelings and somatic manifestations associated with normal grief, but takes it to an exaggerated level. These patients are unable to perform activities of daily living, and they can eventually develop clinical depression. There is chronic or prolonged grief. This is a maladaptive response. It can be very difficult to identify because we do have varying lengths of time required by patients to work through these stages of grief. The patient can remain in the denial stage and remain unable to accept the reality of their loss. Chronic or prolonged grief can result in the patient's inability to perform activities of daily living. And then there is disenfranchised grief. This is a grief that entails an experienced loss that can't be publicly shared or is just not socially accepted. Examples of this would be suicide and abortion. Nursing interventions. To facilitate mourning, we need to allow time for the grieving process. We need to educate our patients and their family on the stages of grief, as well as the tasks associated with the grieving process. It's important to use therapeutic communication and name the emotion that the patient is feeling. Use silence and personal presence to facilitate mourning of feelings. Avoid any communication that would inhibit any open expression of feelings. Examples of this would be false reassurance, giving advice, changing the subject, taking the focus away from the individual who is grieving. When you're relating to somebody who is bereaved, avoid any cliches like they're in a better place now. Instead, encourage that person to share memories about the deceased. Assist them to accept the reality of their loss and support their efforts to move on in the face of the loss. I think that is such an important step. Encourage the building of new relationships. Encourage the patient who is grieving to attend a bereavement or grief support group. And ask them if contacting a spiritual advisor would be acceptable, or encourage them to do so themselves. Psychosocial care, nursing interventions. We need to use an interprofessional approach. We need to discuss specific concerns that the patient and family have, such as financial or role changes, and we can recommend a social service or other referral as needed. We need to facilitate communication between the patient, the family, and the provider. We need to assist the patient in clarifying any personal values to facilitate their decision making. And we need to encourage them to use coping mechanisms that are not maladaptive and that have worked for them in the past. Protection against abandonment and isolation. Nurses can decrease a patient's fear of dying alone. We can do this by making our presence known. This is by answering call lights in a timely manner, as well as making frequent contact. Keep the patient informed of any procedure and data collection times. Let the family members remain with that patient as much as possible. Determine where the patient is most comfortable. If the patient chooses to be at home, move the bed into a central location in the home rather than an isolated bedroom. And support for our grieving families. We need to suggest that these family members plan visits in a manner that will promote the patient's rest. Ensure that the family is also receiving appropriate information as the treatment plan progresses and changes. Provide privacy so that family members can have an opportunity to communicate and express their feelings amongst each other. Educate the family about any physical changes during the active dying process and allow them to express their feelings. Chapter 28, Mental Health Issues of Children and Adolescents. Childhood and adolescent mental health and neurodevelopment disorders are not always easily identified or diagnosed. As a result of this, treatment and interventions can be delayed. As with adults, children and adolescents might meet criteria for more than one mental health disorder, and they can have comorbid conditions. Behaviors displayed by children will become problematic when it interferes with home, school, and peer interactions. Some disorders that can appear during childhood and adolescence include depressive disorders, anxiety disorders, trauma and stress-related disorders, substance use disorders, feeding and eating disorders, disruptive, impulse control, and conduct disorders, neurodevelopment disorders, bipolar and related disorders, schizophrenia spectrum and other psychotic disorders, non-suicidal self-injury and suicidal behavior disorder, impulse control disorders, communication disorders, and tic disorders. Some factors that will impede the diagnosis. Some children might not have language skills and cognitive and emotional development to really describe what's happening to them. And children will demonstrate a wide variation of what we consider normal behaviors, especially in different developmental stages. Some characteristics of good mental health. They should have the ability to appropriately interpret their reality. They should have a positive self-concept. The abilities to cope with stress and anxiety in an age-appropriate way. Mastery of developmental tasks. The ability to express themselves spontaneously and creatively, and the ability to develop and maintain satisfying relationships. Let's look at some risk factors and some etiology. Genetic links or chromosomal abnormalities are associated with some disorders, such as schizophrenia, bipolar disorder, autism spectrum disorder, ADHD, and intellectual development disorder. Biochemical. Alterations in neurotransmitters, such as norepinephrine, serotonin, or dopamine, can contribute to mental health disorders. Social and environmental factors, such as severe marital discord, low socioeconomic status, large families, overcrowding, parental criminality. Substance use disorders, maternal psychiatric disorders, parental depression, and foster care placement are all risk factors. Cultural and ethnic factors include difficulty with assimilation, potential lack of cultural role models, and potential lack of support from the dominant culture. Resiliency. This is the ability to adapt to changes in the environment, form nurturing relationships, exhibit effective coping strategies, and use problem-solving skills. These can all help an at-risk child avoid the development of a mental health disorder. And another risk factor is witnessing or experiencing a traumatic event, such as physical or sexual abuse, during the formative years. Let's look at some risk factors for depressive disorders. This would include a family history of depression, physical or sexual abuse or neglect, homelessness, dispute among parents, conflicts with peers or family, and rejection by peers or family. Bullying, either as the aggressor or the victim. This is going to include traditional bullying and cyberbullying. Engaging in high-risk behaviors, learning disabilities, and a chronic illness. Some expected findings with depressive disorders in children and adolescents include feelings of sadness, temper tantrums, loss of appetite, nonspecific complaints related to health, engaging in solitary play or work, changes in appetite resulting in weight changes, changes in sleeping pattern, crying, loss of energy, irritability, aggression, high-risk behavior, poor school performance or dropping out of school, feelings of hopelessness about the future, and suicidal ideation or suicide attempts. Anxiety disorders and trauma and stressor-related disorders. Some expected findings. The anxiety or level of stress will interfere with normal growth and development. The anxiety or level of stress is so serious that the child is unable to function normally at home, in school, or other areas of their life. Separation anxiety disorder. This type of disorder is characterized by excessive anxiety when a child is separated from or anticipating separation from home or parents that is developmentally inappropriate. This anxiety can develop into a school phobia or a phobia of being left alone. Depression is also common. This type of anxiety can also progress to a panic disorder or a type of phobia. Post-traumatic stress disorder. This is precipitated by experiencing, witnessing, or learning of a traumatic event. Children and adolescents who have PTSD will exhibit psychological indications of anxiety, depression, phobia, or conversion reactions. If the anxiety resulting from PTSD is displayed externally, it is often manifested as irritability and aggression with family and friends, poor academic performance, somatic reports, belief that life will be short, and difficulty sleeping. Let's look at disruptive, impulse control, and conduct disorders. Some expected findings would include behavioral problems, usually in school, home, or in social settings. In children and adolescents with disruptive, impulse control, and conduct disorders, manifestations will generally worsen in situations that require sustained attention, like a classroom, or in unstructured group situations, like a playground. Let's look at oppositional defiant disorder. This disorder is characterized by a recurrent pattern of antisocial behaviors, including negativity, disobedience, hostility, defiant behaviors, stubbornness, argumentativeness, limit testing, unwillingness to compromise, and refusal to accept responsibility for their misbehavior. Children and adolescents with oppositional defiant disorder do not see themselves as defiant. They see their behavior as a response to unreasonable demands and/or circumstances. Oppositional defiant disorder can develop into conduct disorder. Let's take a look at disruptive mood dysregulation disorder. With this, patients who have this disorder will exhibit recurrent temper outbursts that are severe and don't correlate with the situation. Temper outbursts are present 3 or more times a week, and they are observed by others, such as guardians, peers, or teachers, in at least 2 different settings, like the home and school. The mood between the temper outbursts would be angry and irritable, and the onset of this disorder typically occurs between the ages of 6 and 18. There is intermittent explosive disorder. Patients with this disorder will exhibit recurrent episodic violent and aggressive behaviors with the possibility of hurting people, property, or animals. This can be diagnosed as early as 6 years old, but typically occurs between the ages of 13 to 21. More males are affected with this disorder, and it does include verbal and physical aggression. This will prevent the patient's ability to have healthy relationships and employment. It can lead to the development of chronic diseases such as hypertension or diabetes mellitus. Then there is conduct disorder. This can be childhood or adolescent onset. Patients with conduct disorder will demonstrate a persistent pattern of behavior that violates the rights of others or rules or norms of society. Categories of conduct disorder would include the following: aggression towards people and animals, destruction of property, deceitfulness or theft, serious violations of rules. Childhood onset will develop before the age of 10, and males are more prevalent. Adolescent onset will occur after the age of 10. The ratio of males to females is equal in the adolescent stage. Some contributing factors to conduct disorder include parental rejection and neglect, difficult infant temperament, inconsistent child rearing practices with harsh discipline, physical or sexual abuse, lack of supervision, early institutionalization, frequent changing of caregivers, large family size, association with a delinquent peer group, parent with a history of psychological illness, a chaotic home life, and a lack of a male role model. Some manifestations of conduct disorder include a demonstration of a lack of remorse or care about feelings for other people. They will bully, threaten, and intimidate others. They believe that their aggression is justified. They will exhibit low self-esteem, irritability, temper outbursts, and reckless behavior. They can demonstrate suicidal ideation. They can have concurrent learning disorders or impairments in their cognitive functioning. They can demonstrate physical cruelty to others and/or animals. They have used a weapon that could cause serious injuries. They destroy property of others. They have run away from home, and they often lie, shoplift, and are truant from school. Next, let's look at some neurodevelopment disorders. First, attention deficit hyperactivity disorder. This is a very common one. This involves the inability of a person to control behaviors requiring sustained attention. Inattention, impulsivity, and hyperactivity are all characteristic behaviors of ADHD. Inattention is evidenced by difficulty in paying attention, listening, and focusing. Hyperactivity is evidenced by fidgeting, an inability to sit still, running and climbing inappropriately, difficulty with playing quietly, and talking excessively. Impulsivity is evidenced by difficulty waiting for turns, constantly interrupting others, and acting without the consideration of consequences. Inattentive or impulsive behavior can put the patient at risk of injury. Behaviors associated with ADHD need to be present prior to the age of 12, and they also must be present in more than one setting to be diagnosed as ADHD. Behaviors associated with ADHD can receive negative attention from adults and peers. And there are 3 different types of ADHD. ADHD predominantly inattentive, ADHD predominantly hyperactive impulsive, and a combined type, in which patients would exhibit both inattentive and hyperactive impulsive behaviors. Let's look at autism spectrum disorder. Autism spectrum disorder is a complex neurodevelopment disorder thought to be of a genetic origin with a wide spectrum of behaviors that can affect an individual's ability to communicate and interact with others. Cognitive and language development are typically delayed. Characteristic behaviors would include the inability to maintain eye contact, repetitive actions, and strict observance of routines. This type of disorder is present in early childhood and is more common in boys than girls. There is a wide variability in functioning. Abilities can range from poor, such as an inability to perform self-care, communicate, or relate to others, to very high, and this would mimic the ability to function at near normal levels. There is intellectual development disorder. These patients with intellectual development disorder will have an onset of deficits and impairments during the developmental period of infancy or childhood. They will have intellectual deficits with mental abilities, such as reasoning, abstract thinking, academic learning, and learning from prior experiences. These patients will develop impaired ability to maintain personal independence and social responsibility. This includes activities of daily living, social participation, and the need for ongoing support at school. Deficits for this disorder will range from mild to severe. Then there's specific learning disorder. In this, the patient will demonstrate a persistent difficulty in acquiring reading, writing, or mathematical skills. Their performance in one or more academic areas will be significantly lower than the expected range for their age, level of intelligence, or educational level. Patients with specific learning disorder will benefit from an individualized education program, also known as an IEP. Nursing care. We need to assist with obtaining a complete nursing history. It must include the following: the mother's pregnancy and birth history, any sleeping, eating, and elimination patterns, attachment behaviors, a recent weight loss or gain, achievement of any developmental milestones, any allergies and current medications, peer and family relationships, as well as school performance, any history of emotional, physical, or sexual abuse, parental perceptions and level of tolerance towards the child's behavior, the family history, including current members in the household, any substance abuse, including tobacco use disorder, alcohol, and illicit drugs or prescription medications, their safety at home and at school, any actual or potential risk for self-injury, and the presence of depression and suicidal ideation. This would include a plan, the lethality of that plan, and the means to carry out the plan. We also need to know about the availability of any weapons in the house. We need to use primary prevention, which is education, peer group discussions, and mentoring to prevent any risky behavior and promote healthy behavior and effective coping. We can do this by working with patients to adopt a realistic view of their bodies and improve their self-esteem. We need to help them identify and reinforce positive coping skills. We need to employ the use of gun and weapon control strategies and emphasize the use of seatbelts when in motor vehicles. We need to encourage the use of protective gear for high-impact sports. We need to reinforce education on contraceptives and other sexual information. We need to encourage abstinence, but keep the lines of communication open to allow the adolescent to discuss sexual practices. We need to encourage patients and their family members to seek professional help if indicated. We also, as nurses, need to intervene for any patients who are engaging in high-risk behaviors. We need to instruct the patient and their family member on these factors that will contribute to substance use disorders. Make sure to make appropriate referrals whenever they are indicated. We need to inform the patient and family about support groups in the community for eating disorders, substance use disorders, and general teen support. We need to instruct the patient regarding individuals within the school environment and the community to whom they can talk to about their concerns regarding personal safety and bullying. This would include police officers, school nurses, counselors, and teachers. We need to make referrals to social services when indicated and discuss the use and availability of support hotlines. We need to assist with depression and perform a suicide assessment. We need to make an immediate referral for any professional care when indicated. Some interventions that nurses can employ with various disorders. For anxiety disorders, we need to provide emotional support that is accepting of regression and other defense mechanisms. For trauma and stressor-related disorders, we need to encourage group therapy. For disruptive and impulse control and conduct disorders, as well as ADHD, we need to use a calm, firm, respectful approach with the child. We need to use modeling to show acceptable behavior and obtain the patient's attention before giving any instructions or directions. We need to set clear limits on any unacceptable behaviors and be very consistent. Assist with planning physical activities through which the patient can use energy and obtain success. Support the parent's efforts to remain hopeful and provide a safe environment for the child and others. Assist the child in developing effective coping mechanisms. For autism spectrum disorder, we can recommend referrals such as physical, occupational, and speech therapy as indicated for early intervention. We should provide a structured environment. We need to use short, concise, and developmentally appropriate communication. We need to identify desired behaviors and then reward them. We need to role-play situations that would involve conflict and conflict resolution strategies. Encourage verbal communication. Try to limit any self-stimulating and ritualistic behaviors by providing alternative play activities, and always give plenty of notice before changing a routine. For communication disorders, you need to first rule out autism spectrum disorder, then recommend a referral for a hearing test. You also need to recommend referrals for occupational and speech therapy as indicated for early intervention. For tic disorders, we need to identify specific behaviors associated with the disorder, then redirect the tic behavior. Reinforce behavioral therapy techniques such as habit reversal and comprehensive behavior intervention therapy. We need to allow a specific time in which the patient is allowed to share their feelings related to their tic behaviors. Medications that we can use. For ADHD, we primarily use psychostimulant drugs and non-stimulant selective norepinephrine reuptake inhibitors. For autism spectrum disorders, we use selective serotonin reuptake inhibitors and antipsychotic medications. For intermittent explosive disorder, we use selective serotonin reuptake inhibitors, mood stabilizers, antipsychotics, beta blockers, and anticonvulsants. For oppositional defiant disorder, medications are not generally prescribed. However, we can use stimulants or anticonvulsants to manage any comorbid conditions. For conduct disorders, medications are prescribed to target the specific problem behavior and would include stimulants and third-generation antipsychotic medications. Antidepressants, adrenergic medications, and mood stabilizers can also be used to manage aggression. For anxiety disorders, there are no FDA-approved anti-anxiety medications for children. For PTSD, the medications will be prescribed to target the specific problem areas associated with that disorder, such as the depression or the ADHD. And for disruptive mood dysregulation disorder, we can use antidepressants, antipsychotics, or stimulants to manage the comorbid condition. Interprofessional care. The family therapy will enable the patient and family to address their problems. Cognitive behavioral therapy can be useful to change negative thoughts to positive outcomes whenever intervening for depressive, disruptive, impulsive control, and conduct disorders. Other therapeutic approaches include group therapy, play or music therapy, and mutual storytelling.